And thank you for the opportunity today to discuss the HIQA review of urgent and emergency healthcare services in the Midwest. We continue to be fully committed to delivering the highest quality healthcare services nationwide, including the University Hospital Limerick and the Midwest region. And in speaking to the House today, I want to first acknowledge the really hard work, the expertise and the consideration that HIQA put into producing their recent review and their advices to me. I also want to acknowledge the significant work undertaken by the ESRI, who contributed important research relating to the future bed requirements for the Midwest, which I think greatly informed HIQA's advice. I think we can all agree without hesitation that the people of the Midwest region deserve access to responsive, safe, urgent and emergency care in a safe and timely way. Much has improved in Limerick over the past 12 months, and to add to that, I was delighted to open the first of 2 new 96-bed blocks at University Hospital Limerick last month. Those beds were very, very much needed. And the opening was important not just for Limerick, but for the entire Midwest region. The new bed block has already had a positive impact on capacity and reducing overcrowding. Since its opening, we've seen days this month, last weekend, where UHL reported on the HSE figures, which is our standard one of measuring, 9, 5 and 7 people on trolleys last weekend. The same day last year, those numbers were 80, 75 and 59 respectively. We've definitely seen a major impact by the 96-bed block on the trolleys in Limerick. It's not a universally perfect picture by any means, but the difference in what's experienced in Limerick in the last number of weeks since the bed block has opened is quite considerable. The average trolleys the 2 weeks before the bed block opened was 54. The average trolleys for the 2 weeks after were 20. And as I look at the difference, essentially at random, between my first pages of trolleys and my most recent pages of trolleys from January, we're looking at figures in Limerick of 72, 77, 57, 88, 91, 69. If I look over the last number of days, 7, 6, 13, 30, 27, 28. 28 people being too many, but it's a very considerable difference. It's a very considerable improvement and the trajectory that we know we need to see. It also, when I look at all of the hospital trolley figures every day, and you can see this is January, red, a lot of red. This is the last few days, the last 7 or 8 days, much less red. I can see in Limerick in particular the fact that it really does come down to beds, because they have made extraordinary improvements in all of their processes, particularly in the emergency department. We know in large part that is because of the implementation of the excellent Frank Clark report, the independent investigation by retired Chief Justice Frank Clark into the tragic death of Aoife Johnston at UHL in December 22, and that identified several factors that contributed to delayed treatment and contributed to Aoife's death. And my thoughts continue to be with her family, and I was so grateful to have the opportunity to meet with them this year. The report highlighted particularly severe pressures that night in the emergency department, and the HSE established a structure to oversee the implementation of the 17 recommendations made by the report immediately after it was published in September 2024. Work to close out that implementation has concluded and shared with my department last month. The outcomes from that report do contribute to an improved patient safety situation in the HSE Midwest region and across the healthcare system in Ireland generally, because other departments are learning from that and learning from the experience in Limerick, who, as I said, have transformed their processes generally in the emergency department, but also in other parts of the hospital in that period since, I suppose, December of 2024, within the last 12 months. Specifically on the HIQA review, my predecessor, Stephen Donnelly, in 2024 requested HIQA to conduct a review, as you're aware, of the urgent and emergency care in the Midwest region, with the primary objective of ensuring safe, quality acute care. And as part of that review, HIQA was asked to consider the case for a second emergency department in the context of population changes in recent years and ongoing pressures across the Midwest. That final report was submitted by HIQA and published at the end of September 2025. And as senators are aware, the report presents 3 options and advices for me as to how to best address the capacity gap. Those include the expansion of capacity at UHL on the Dooradoyle site, that's option A. The extension of the UHL hospital campus to include a second site in close proximity under a shared governance and resourcing model, option B, and the development of a Model 3 hospital in HSE Midwest, providing a second emergency department for the region, option C. But more than anything else, as senators are aware, the report clearly identifies that the lack of sufficient acute inpatient beds in UHL and the Midwest region is the core issue that needs to be addressed urgently, and that is my priority. In addressing the issue, we do it as we continue to increase capacity, as we try to increase capacity generally. 278 beds have opened there in acute hospital since January 2020, including two 16-bed rapid build units delivered in December 2024 and June 2025, and indeed the 96-bed block which I opened last month. 236 of that 278 are in UHL, and as we can see, we see the impact on patients waiting in trolleys. Enabling works, and I've seen it myself, for the second 96-bed block at UHL, and a further 84 inpatient beds planned at UHL are underway. Those projects, including the 32 rapid build beds and the first 96-bed block, do increase the bed capacity by up to 308 beds by 2028. So since 2020, we'll have had 572 new inpatient beds across the region in 2031. I know that's sort of lots of numbers and it's hard to imagine, but I think the most striking thing for me was to stand in the soon-to-be opened 96-bed block and look down and see the second 96-bed block about to be developed. And the pressure and the reason it didn't happen at the same time was, of course, some of our outdated rules in relation to procurement and infrastructure guidelines, which I know that Jack Chambers will be bringing measures to Cabinet next week to change. Other really important initiatives include the acute virtual ward for 25 patients, which went live last year. And we want to extend that up to 40 patients. That's like 40 beds. That's 40 people who can be at home under the care of Limerick, in their bed, on their couch, properly remotely monitored. It's working well in Limerick, it's working well in Vincent's, and we're expanding that across 5 more hospitals now. It really, really works quite well, and we've had very good outcomes, and we'd like to see more of that. And of course, the Limerick Surgical Hub, which will open in the summer of 2026. And we will begin recruitment for that in advance. It's so very important. And the idea is to pull as much work that doesn't have to be in the hospital, elective work and other day case procedures, out of the hospital to free up capacity for other things. Staffing has grown by 53% since 2019, including 300 more whole-time doctors, including consultants, 571 more nurses and midwives, and 163 more health and social care professionals. All of those improvements show our commitment to increasing capacity and de-escalating the pressure experienced in the UHL emergency department more broadly. I also want to compliment the work done by the Regional Clinical Director, Catherine Peters, and the overall REO, Sandra Broderick, and the Patient Council, who all together have done extraordinary work on changing processes in Limerick. Limerick has the lowest proportion of POC consultants, public-only consultant contracts, and is working with the 2008 contract holders in a really excellent way to make sure that there are more people working at weekends. They're discharging better at the weekends, they have the highest presentations, they're discharging the best, they're rostered the best at the weekend. They really have taken every possible step, and what they need is more beds, more acute capacity, and it is very, very clear. I've met with the Patient Council, and I will meet them again, and last night I met with a cross-party group of senators and TDs to discuss next steps of the review and outline my thinking for them. And I really do thank them sincerely for their collaborative work. Everybody here is simply here to improve services for the people of the Midwest, whom they represent and whom I have obviously a major obligation to. My intent, as I said to deputies and senators last night, is to bring a memo to government before Christmas to do a number of different things. One is to show how we're going to bring further option A and option B, particularly in the context of the new infrastructure guidelines that I hope will be approved by Cabinet next week. That is a really, really important enabler for us. The reason that we didn't do 2 96-bed blocks at the same time was the infrastructure guidelines and how difficult and slow that has been in the past. So this is an important enabling change, and I need to see how that intersects with our plan for option A in particular. I believe we need to get as much out of the Dooradole site as we possibly can, while exploring and delivering the other options as well. So the memo before Christmas, my intent is that it will deal with option A and option B together, and also a really substantial plan for how we can increase not just infrastructure capacity in Ennis and Nina, recognising there are very many more beds, and I should have spoken to that earlier, but there's an additional 48 beds, for example, going into Ennis on top of the 81 that are there. That's a very considerable expansion, and something of a similar order in Nina. Also more radiology, also more other medical facilities, disinfecting facilities and so on. But what we haven't fully explored, and what I have asked the HSE to do, is to give me a plan about how we can deliver more services from Ennis. So what am I talking about? I'm talking about cancer treatments that can be delivered closer to home, having had the major diagnosis and the treatment plan in the acute hospital. What more can we do to deliver services? So my intent is to bring a memo dealing with those 3 things in particular, and also to agree a process for how we will address option C, which I think takes a longer-term needs to take a longer-term approach, a longer-term analysis in terms of what is the perfect size for a hospital, how is that best governed. We have a genuinely clean slate here, and we're learning so much about the perfect hospital size in terms of efficiency, governance, clinical integration, and I think the Midwest is a big opportunity for genuinely good thinking on that, and thinking about what we have learned from the project, from the very important work of the Infrastructure Accelerator Task Force that have been working with the Department of Public Expenditure and Reform for the last, from the project, from the very important work of the Infrastructure Accelerator Task Force that have been working with the Department of Public Expenditure and Reform for the last 6 months or so. So we have a major project of work. In my mind, I divide it into 2 sections. Prior to Christmas, dealing with the priority area of delivering acute capacity, which is what HIQA has said is necessary. So that must obviously be our priority first. And then in the early part of 2026, having a proper structure that enables us to consider all of the factors about how we will deliver capacity for the longer term in the Midwest. Thank you.